So hi, I'm Brian Hurley. I am the Director of Addiction Medicine for the County Department of Health Services, and I'm also an Assistant Professor of Addiction Medicine in the UCLA Department of Family Medicine. And thanks for joining me this afternoon on a webinar on medical cannabis and addiction medical practice. I have no conflicts of interest to disclose. So although I work for UCLA and I work for the County of Los Angeles, I don't work for any companies that will try to sell you anything today. And this is what the raw marijuana plant looks like for those of you that haven't seen it before. So I'll put it on here for the shock and awe value. And the marijuana plant itself actually occupies a unique regulatory status. So the marijuana plant is considered by the U.S. federal government as something called a Category 1 controlled substance in the Controlled Substances Act, which means that there is no acceptable medical use for the plant itself. And there are some substances that occupy multiple tiers in the Controlled Substances Act. So for example, cocaine and methamphetamine are in both Schedule 1 and Schedule 2. There are some accepted medical uses, but they are also considered to be Schedule 1, no accepted medical use. Marijuana, though, does not, itself does not occupy, as a plant, multiple schedules. It exists as a Schedule 1 drug. And that also means that although there are components of marijuana that have been approved by the U.S. Food and Drug Administration for specific medical indications, the actual plant itself is considered federally to have no acceptable medical use. And so given that federal sort of frame, states have actually, individual states have actually passed legislation to regulate marijuana differently than the federal regulation of marijuana. And so here's a slide that goes through marijuana's legal status in various states. And actually last pulled the slide, it's about a year ago. So this may not actually be fully updated, but I reside in Los Angeles, California. I live in a state where marijuana has been legalized by our state government for recreational use. And that's true in Maine and Massachusetts and in Oregon and Washington, Nevada, Alaska, and Colorado. But there are other states where states have passed what's called medical marijuana legislation. That is, marijuana is not available generally, but it is available outside of the pharmacy in shops that have been designated by the states to be able to sell marijuana to people for purported medical indications. And when I say purported medical indications, let me be clear, the federal government has said that marijuana is a Schedule 1 drug, and so the plant itself has not been FDA approved for any particular medical indication. But there are countless examples of, and actually reports of people finding medical benefits from consuming, and consuming can be smoking, but there's other ways of sort of consuming the cannabis plant, of consuming cannabis outside of one of the FDA-approved cannabinoid medications. And so in Massachusetts, for example, in 2013, the Massachusetts Medical Marijuana Initiative eliminated criminal and civil penalties for the possession and use of up to a 60-day supply of marijuana, and also authorized that those residents that have a registration card from their physician are then able to purchase cannabis. And there is a common misconception around what is sometimes referred to as medical marijuana, which is there's nothing actually different about the marijuana that's sold for purported medical indication. The marijuana that's sold through medical marijuana shops, the only difference is that the buyer has to have this card, this registration card authorizing their purchase. And so therefore marijuana can't really be prescribed, the plant itself, right? I can prescribe THC, either synthetic or not synthetic THC. I can also prescribe a cannabidiol, right? So Epidiolex is now FDA approved. So I can prescribe cannabinoids, but I can't actually prescribe the marijuana plant. As a physician, if I choose to, I can authorize people to have a card where they can then go use the card to purchase marijuana. And the card is different than a prescription. What the card does is protect the purchaser of their marijuana from criminal penalties, right? So it protects them from any legal consequences that the state might have otherwise levied against them had they not had the card. And so I grew up in the state of California, and so I was in California was the first state to legislate medical marijuana. And really the way that it worked was the advocates said, look, there are people with medical conditions that do not respond to existing treatments, but do respond when they consume the marijuana plant. And so for compassionate use, can we authorize physicians to give people a card to protect these people from being prosecuted or arrested if they're found to have marijuana because it helps them with their medical conditions? And that was really the idea, the frame under which medical marijuana came out of. But it's not, marijuana can't really be prescribed in the same way that I might prescribe a medication with a specific dose or with a specific strength, because the marijuana plant isn't regulated by the FDA, right? So when a shop sells marijuana, there is no federal standard under which that marijuana is tested compared to, say, a pharmaceutical agent. Again, in Massachusetts, home use and cultivation was permitted in 2016. In July of 2018, recreational cannabis was permitted out of licensed dispensaries that were licensed by the state of Massachusetts. The qualifying medical conditions, again, in Massachusetts, the physician would have to affirm that the patient has cancer, glaucoma, HIV/AIDS, Hep C, Lou Gehrig's disease, Crohn's disease, Parkinson's disease, multiple sclerosis, or what was designated other debilitating conditions as determined in writing by the qualifying patient certifying physician. And the legal language used in Massachusetts mirrors a lot of the language that's used in other state regulations. Some state regulations are looser, some are broader, some are more specific, some are looser around what counts as a qualifying medical condition. But nonetheless, these types of legislation of the type that Massachusetts developed mirrors a lot of the legislation that many other states have put into place. And if you haven't seen what a medical marijuana card, this is a sample card that pulled off the internet that again comes from Massachusetts, so you get an idea of kind of what they look like. And again, it's not a prescription. If I'm a physician choosing to recommend medical marijuana for a patient, I'm not giving them a prescription for a pharmaceutical. I'm giving them a card that protects the patient from criminal prosecution if they then go and choose to buy marijuana using the card. So there are 113 active cannabinoids in the cannabis plant. The two main ones that we talk about are tetrahydrocannabinol and cannabidiol. And tetrahydrocannabinol, or THC, is the psychoactive part of the plant that, for lack of a better term, gets you high. It's responsible for the intoxicating effect. It also is responsible for some of the, or thought to be responsible for some of the analgesic effects. Cannabidiol is also a psychoactive component. It's actually thought not to really have much psychoactivity in terms of euphoria. It does seem to have some antipsychotic and anti-anxiety effects. And there are also thought to be some seizure relieving effects from cannabidiol. And the combination of THC and CBD has been sort of well described and studied in literature, where there's some thought that THC can have a pro-psychosis effect, but CBD has sort of an anti-psychosis effect. THC has an anxiety-promoting effect, but CBD has a anxiety-relieving effect. And so there are people that sort of play around with different strengths of combinations of THC and CBD. And many of my own patients actually go purchase CBD, saying that it is helpful on its own as an anxiety reliever, although I would also say anecdotally that many of my patients that get CBD choose to buy versions of, say, CBD oil or CBD capsules, or even the raw plant with various CBD THC combinations, that virtually all of which have some THC in them. So many patients, even if you try to get pure CBD, oftentimes THC is mixed in because oftentimes makes the substance more rewarding. So this is how marijuana is prepared. There is, what we think of as just raw marijuana or weed is dried flower tops and the leaves of cannabis. And so on the left side of this slide, you can kind of see what the leaves look like when they're dried out. It can be rolled into something that looks kind of like a cigarette, and that's called a joint. Or it can be rolled into a bigger cigar-looking, device is the wrong way of putting it, formation, there we go, into a cigar-looking formation that's called a blunt. Hashish is the extracted resin from the flowers compressed into bricks, and this is what hashish looks like, and that can also, it's usually ignited at the end of a pipe and smoked. Hash oil is when you run a solvent through the cannabis plant, usually the dried cannabis plant, to extract out those psychoactive components like THC and CBD. And the solvent that's typically used to make hash oil is butane, because butane evaporates off. So you sort of put the plant, push the butane through, get the oil out. The butane then typically then evaporates off, and then you have this highly viscous mass. And hash oil, as you can imagine, is very, very concentrated with THC, CBD, really, in fact, any of the psychoactive component or any of the active components of the plant. That's very highly concentrated THC. And there's a couple ways you can use it. People can put hash oil into the cartridges that go into electronic cigarettes. So those are cartridges that then heat up the solution, which in this case would be hash oil solution, and then mix it with something called polyethylene glycol that then you inhale. That's one way of using hash oil. The other way is to put it at the top of a pipe, and that's what you see on the left, and then heat the tip of the pipe that then evaporates the solvent, and then you inhale it, and that's called dabbing, dabbing hash oil. And as you can imagine, with chemistry, you can put THC or CBD products into almost anything. They can be into liquids, they can be into solids, they can be into food, they can be into patches that go transdermally. There's a whole lot of ways of delivering cannabis, and there's an entire industry now of cannabinoids that are added to foods and other products. And I'll just, and then, you know, the cannabinoids can be added to tabs and capsules, some of which have marijuana plants in them, some of which just have oils or other solvents in them. And then one thing that's not a cannabinoid, but which kind of looks like a cannabinoid, are these synthetic cannabinomimetics. The synthetic cannabinomimetics are actually not, they're not related to THC or CBD, but they are synthetic molecules that bind to the cannabinoid receptors in the brain. They're actually enantiomer receptors in the brain, but they bind to the things that THC and CBD bind to. I should say THC and CBD, really most of the synthetic cannabinoids like K2 are things that bind to the CB1 or cannabinoid 1 receptors, which is where THC has most of its activity. And THC itself actually does not super strongly bind to the CB receptors. It's a partial activator of those receptors, whereas K2 is a full kind of has a full effect on those receptors. So I'm not going to spend a ton of time going through the brain chemistry, but I will just sort of acknowledge that the cannabinoid receptors are expressed really at all levels of the brain, near the outside of the brain, which is called the cortex, or in the inner parts of the brain. It's in the brainstem, it's in the hippocampus, it's in the basal ganglia, it's in the cerebellum. And so people that regularly consume THC products, you'll notice that when somebody's intoxicated, they move slower, which is thought to be related to both the basal ganglia and the cerebellum. Oftentimes there are cognitive slowing, which is in the cerebral cortex. And there can sometimes be memory problems and appetite stimulation that, again, is thought to be related to these brain areas. And the spinal cord too, right? So the peripheral gray is an area that transmits pain and other types of sensations that the CB receptors are expressed. And I mentioned the active ingredient THC of cannabis binds to the cannabinoid receptor. That's the red receptor that's in this kind of complicated graphic. But it's that receptor that seems to be responsible for most of, like I said, the sort of pro-psychosis, pro-anxiety, and euphoric elements of consuming a cannabinoid. And it's the K2 synthetic cannabinomimetics that really do seem to be much more activating of this receptor than regular THC. And so what we see with regular THC is people have this kind of pleasant but typically low activity high. But what we see with the synthetic cannabinomimetics, because again, you don't have any cannabidiol, you don't have any other balancing agents that sometimes are present in a regular marijuana plant. When you use a synthetic cannabinoid, people tend to have a much more sort of activated intoxication. So that's where you see people that actually can look somewhat psychotic related to the full activation of their receptors with like a synthetic cannabinoid. So this is what intoxication looks like, right? When people are intoxicated with marijuana, they oftentimes look and feel euphoric. They notice that their sensations feel different, and they notice the sensation of time feels slowed. One of the things that you can see in people that are intoxicated with marijuana is their eyes are red, their mouth is dry. We notice their heart rate and blood pressure go up a little bit, and that if they were to sit or stand up quickly, their blood pressure would drop. So if any of you have ever seen somebody who's actively intoxicated with marijuana, if they stand up too quickly, sometimes people feel faint. And if you ask people to perform complex motor tasks, you'll notice that people's motor coordination is impaired. There are undesired effects too. People that smoke marijuana a lot tend to have more social withdrawal and are less socially connected to people that don't. There is some cognitive and judgment impairments that happen when people are intoxicated, and some short-term memory loss. And then there is a couple other effects of intoxication I should talk about. One is when somebody is intoxicated, they sometimes have elevated anxiety and paranoid symptoms. They sort of feel like, something's out to get them or something's chasing them. But there's another effect of regularly using marijuana, which is regularly using marijuana seems to be statistically associated with an increased rate of developing schizophrenia or bipolar disorder with psychotic features. And so that's one of the, the big public health risks is the more marijuana is used, the more it might unmask schizophrenia or bipolar disorder in patients who may not have otherwise developed those. And just to be clear about the prevalence of schizophrenia in the United States is about 1% of the population. And, again, for bipolar disorder, it's in the well less than 10% of the population, right? So, and I think the last time I looked, it was like 3 to 5%. When people smoke marijuana heavily, it about doubles that risk, which means that most people that smoke marijuana do not develop schizophrenia or bipolar disorder with psychotic features, but rather there are people that are, at risk of developing those conditions, and the smoking marijuana seems to put people at increased risk of then developing those psychiatric syndromes. And it's not the same as, oh, I smoke, so I got paranoid, so I'll stop smoking, I won't be paranoid. That's not what I'm talking about. I'm talking about like people are smoking regularly, the intoxication effects may have worn off, right? They may no longer be smoking, but then they're at an elevated risk of developing these chronic psychotic disorders that are really co-occurring, right? That is to say, they are independent disorders that have their own symptomatology and timeframes that is not related to the cycle of intoxication withdrawal from cannabis. The National Academy of Sciences has a whole paper talking about the evidence and recommendations for research. And there is some evidence that marijuana does stimulate the appetite and suppress nausea and vomiting. There's also thought that marijuana can help relieve certain types of chronic pain. Not all pain is the same, and there are purveyors of cannabinoid products that talk about THC as a big pain reliever. In fact, there was a study one of my colleagues who's now in Louisiana did, where he looked at, does using marijuana seem to change the rate of opioid overdose, and looked at, the states that have loosened marijuana laws, either medical marijuana laws or legalized marijuana laws. What's their rate of opioid overdose compared to the states that don't? And there was some early evidence suggesting that the more that medical marijuana was available, the less there was an opioid overdose. But then another one of my colleagues this year actually published a refutation of that, looking not just at like what is an ecologic study, looking at states that have these laws and overdose rates in those states, which is somewhat complicated. There's a number of confounders which might explain the relationship between those two. It actually looked at marijuana use being associated with an increased rate of opioid overdose. So the question of whether or not marijuana use is protective against opioid overdose or opioid use or opioid overdose appears to be actually a relevant scientific question. And the more recent evidence suggests that marijuana is at the very least not protective, if in fact potentially increases the risk related to opioid use. At any rate, so related to pain, the National Academy of Sciences said there's certain types of pain that do seem to respond to marijuana, but I myself would hesitate to sort of promote marijuana as a primary pain reliever, just as there's some kind of pains that respond to like SSRIs or other types of things that aren't typically analgesic. I suspect that there's certain types of pain that would respond to THC or cannabidiol, but at the same point, I wouldn't necessarily want to promote THC or cannabidiol as a first-line agent for pain, given the available alternatives. Some spasticity appears to be better, or it seems to improve when people use cannabinoid products. Glaucoma can reduce eye pressure. And it appears that CBD in particular has some helpful anti-seizure properties in certain types of epilepsy. And again, this is from the National Academy of Sciences. And I'll just sort of say one other thing about this. So the regulatory framework for marijuana has evolved such that states have now said, we will not prosecute people that sell marijuana, either, in states with medical marijuanas, we won't prosecute people with medical marijuana cards. And in states that have legalized marijuana, we're not going to prosecute sellers or buyers of marijuana. The challenge with that is that because there are we know that there are some medical effects from some components of the marijuana plant. There are now industries that are going to promote cannabinoid products and that are not subject to any kind of FDA review or approval. There's people that sort of say, oh, take CBD for anxiety or THC for pain, any kind of anxiety, take cannabinoid products or smoke marijuana for PTSD or depression or any kind of mental illness. And I've seen, at least in my state, California, we're sort of running the risk of cannabinoids taking on kind of a snake oil effect. That is, the people that sell marijuana are able to sell it for virtually any kind of condition that they want to sell it for. And because it's been approved by the state for medical use, there is some suggestion that, well, then maybe they're right? Maybe you could use marijuana for various medical indications. But because the federal government says that marijuana still has no medically acceptable use, there's no regulation of the statements made by people in the marijuana industry. So we're in this kind of like tricky state where I have patients come to me all the time of like, oh, there's marijuana and it's great and it has no side effects. And, it works for every kind of medical condition there ever is. And I'm thinking, well, these are claims made by a highly unregulated industry that's mostly now around, moving sales of its product and can sort of make, is now in a legal system where they seem to be able to make various claims without any evidence or support because the state has said marijuana has purported medical uses, but the federal government is not in a position to regulate those statements because, again, the FDA doesn't regulate marijuana. Anyway, so this was the paper I mentioned before, Marcus Backerber, who suggested that medical cannabis laws were associated with reduced opioid analgesic overdose rates. There was another study, and I apologize about don't having a slide set at the moment, refuting this. But we do know that marijuana is not risk-free. On one hand, we know that at this point, I don't think there is the opinion among epidemiologists or people in public health that marijuana does substantially reduce the risk of overdose. And we do know that cannabis use diminishes learning capacity, is associated with school performance deficits, is associated with the emergence of psychotic illness, which is something I mentioned before around, unmasking schizophrenia or bipolar disorder psychotic features. And marijuana is addictive. There are, in fact, I remember the initial version of the legislation that went to the state house in California actually would have said that the state of California finds that marijuana is not addictive, and that's simply not true. There are people who have cannabis use disorder. It is a medically defined condition, and most people who smoke cannabis do not have they do not have a cannabis use disorder. We know the lifetime risk associated with cannabis addiction after somebody smokes it is around 9%, right? Which means that most people that are exposed to cannabinoids do not have a cannabis use disorder, kind of akin to most people that drink alcohol don't have an alcohol use disorder. But it is also not addictive, if that makes sense. Or it is an addictive drug and is associated with people developing a cannabis use disorder. So what do we know about people that go to addiction treatment, right? So I'm going to transition from cannabis in general and talk about addiction treatment. We know that people that seek treatment, and again, this was a study done by my colleagues at BU, Jeff Samet, Rich Sage, and company, that looked at the addiction health evaluation and disease management study. So people who came from a residential detox unit in Massachusetts and asked people about their cannabis use. And they found that the more people smoke cannabis, they reduced their odds of being abstinent from drugs or heavy alcohol use, heavy drinking. So there is some suggestion that people that smoke cannabis are less likely to have a relationship of abstinence with whatever other drug of choice they might have been admitted. And if they're coming from a detox unit, it would have been alcohol or opioids, so or sedatives. So smoking marijuana, again, or using marijuana, was associated with less abstinence among other drugs or alcohol. And this actually mimics what we know from the tobacco literature. We know that the people that continue to smoke tobacco cigarettes are actually also less likely to remain abstinent from whatever drugs they came to treatment for. So smoking cannabis does not help, it does not appear to help in people's recovery. That said, does it then impair the effect of other types of treatments? Well, there are a couple studies looking at cannabis that's being used by people who are in opioid use disorder treatment. And this is a buddy study that is, gosh, now over 20 years old, looking at participants that had an opioid use disorder in an outpatient view clinic. 60 or about 60 of them smoked cannabis and 25 didn't. And the people that the people that did smoke cannabis really used it throughout the study period. And they found that people who smoke cannabis were less likely to be married, were more likely to have financial problems, were more likely to be involved with selling drugs, and more likely to have shared needles compared to people that didn't smoke cannabis. But there was no difference in treatment retention, in illicit or non-prescribed opioid use, in other substance use, or in their ASI, or Addiction Severity Index score. So this study really then suggested to us that we could prescribe buprenorphine to treat opioid use disorder, regardless of whether the person smoked cannabis. And that while smoking cannabis was associated with sort of more risky behavior, it didn't affect the core treatment outcomes, which are treatment retention, opioid use, other substance use, or addiction severity in general. It didn't seem to affect the treatment outcomes. So at least the buddy study supported that we could safely prescribe buprenorphine to people who smoke cannabis. Church, a couple years later, did a similar study, but in this time, rather than looking at buprenorphine for the treatment of opioid use disorder, it was looking at observed daily dosing of oral naltrexone. Now, oral naltrexone is not a recommended treatment for opioid use disorder. Injectable naltrexone is, if you're going to use naltrexone, is the preferred agent. But prior to the FDA approval of naltrexone, or naltrexone long-acting injection in 2010, we had oral naltrexone was one of the only other alternatives. And so this behavioral naltrexone therapy that looked at MET and community reinforcement and network therapy to sort of retain people in treatment, did not find that people that smoke cannabis actually responded to daily observed dosing or this behavioral naltrexone therapy any different compared to people that didn't smoke naltrexone. Kevin Hill in 2013 looked at youth in a opioid use disorder program that where buprenorphine was prescribed. And they looked at daily cannabis users versus non-users versus occasional users. And again, there was no, it appeared that using cannabis did not increase the rate of people using non-prescribed opioids. And that all participants reduced their opioid use on buprenorphine, and regardless of whether they smoke cannabis. So again, this was a study again supporting the sort of safety and efficacy of using cannabis in a buprenorphine clinic. So I do want to talk about cannabis and naltrexone specifically because there's a couple sort of conflicting studies. Cooper in 2010 looked at, this was a small study of like 30 marijuana smokers, and it gave people variable doses of naltrexone. And then had them smoke marijuana. And they found, at least in this Cooper study, that the cannabinoid effects seem to be enhanced by naltrexone, kind of regardless of the dose of naltrexone that was given. And then the Haney study in 2015 looked at, again, it's a small study, 53 users, and found that naltrexone seemed to decrease the subjective effects of marijuana in people that took naltrexone. So we have one study suggesting that there might be an effect and another suggesting that there isn't. And I'll tell you the clinical significance of this for me, I still absolutely prescribe naltrexone to cannabis users. I don't withhold naltrexone for people that use cannabis. But I do ask whether or not they notice that after they start on naltrexone, whether or not they have noticed that the marijuana that they use feels any different. And I have yet to have a patient report to me that that naltrexone has affected the way that cannabis is affecting them. But there were some studies suggesting that there could possibly be an effect. But again, these are small studies that really suggest that there could be, but they're not definitive. So I would suggest that there are some policy implications to this, right? We know that cannabinoids are associated with risks. And we know that the earlier that people use potentially addictive substances, and cannabis is a addictive substance, they use addictive substances, the more likely they're going to go on and develop a substance use disorder. And this follows actually what's called the learning model of addiction. So the disease model of addiction is that there are people that have a predisposition, and if they're exposed to a substance, then go to develop a use disorder on that substance. And that appears to be sort of validated now, or not appears to be, it has been validated now in a number of studies sort of looking at the neurochemistry behind addiction. A comparable, or oh gosh, what's the right word I'm looking for here? There is a complementary model of addiction called the learning disorder model, which is this idea that the earlier people use a substance, and the more that they use that substance to sort of regulate themselves, right? So the more that people are like, oh, if I'm going to celebrate, I go celebrate with cannabis. If I go get stressed out, I'm going to go get stressed out and, use cannabis to deal with it. If I'm bored, I'm going to use cannabis. If I'm, overwhelmed, I'm going to use cannabis. If I wake up, I go use cannabis. The more you sort of learn to incorporate cannabinoids into your life, the more limited development you have to develop, like this is how I can manage when I'm feeling bored, when I'm not using cannabis, or as I, can manage celebrating without using an intoxicating substance. And so the earlier people develop this sort of learned behavior of using cannabinoids to regulate themselves, the earlier people do that, the more chance that they're going to use cannabis in a way that's disordered. So as a result, there's this CSAM, California Society of Addiction Medicine, has this youth first report that says really there's a lot of benefits of limiting cannabis access to those under 21. The idea being that the earlier we expose the developing brain to an intoxicating substance, the more likely that people are going to develop a use disorder on that substance. So limit cannabis access until people's brains have developed to the point where they can learn how to make decisions and regulate themselves without using cannabis. And the age of 21 is actually arbitrary because we know that the frontal lobe and decision-making capacity in the human brain really seems to develop up to the age of 25. So if we were to just follow the evidence, we would probably put the restricted age at 25, although again in our country we set the age of legal sale for intoxicants like alcohol and cigarettes and now cannabis to 21 typically. The best way, if you're trying to avoid a cannabis use disorder, is to keep youth engaged in their lives, and it typically means school. So keep youth engaged in school, which is where most people's that when you're a kid is really your occupation, right? Is to be in school and to perform academic tasks, and that's also where people generally develop their friend group and their social network. And we do know, at least from the addiction literature in general, the friend groups and social networks make a really powerful effect on whether people do or don't then go on to develop a substance use disorder. Nonetheless, despite the best efforts, there are people who smoke cannabis who develop a cannabis use disorder. And so provide schools with the resources to identify and help students using cannabis, and construct a community-based intervention to evaluate youth who are using cannabis problematically. So, make the alternatives to cannabis really appealing and available, but then also support people at the time when they're ready to, when they might be ready to do some treatment. And then provide educational and constructive interventions, including professional treatment for those that have developed a cannabis addiction. There's a couple other things that I'll throw out, some tools I would recommend. So when people come to the office and they talk about their cannabis use, people oftentimes have a variety of attitudes, right? So there are patients who, let's say, have developed an opioid use disorder who may continue to smoke cannabis, but they look at cannabis almost like the way that some patients look at cigarettes. Yes, I smoke cannabis, but I know that I shouldn't. And one way of eliciting that is to ask. And when I say ask, when people may come to treatment, it's like, oh, you have to stop using cannabis. You might say, okay, well, rather than sort of jumping in and saying, okay, tell me more about your cannabis use. What do you understand about marijuana or its effects? And then when somebody answers you, you have an idea. If somebody says, well, I know that there's two psychoactive drugs, there's two major psychoactive components, there's THC and there's CBD, and I know that those seem to have, effects on euphoria and psychosis and anxiety, and that it puts me at risk for X, Y, and Z, right? It saves me the time of needing to educate that person. Conversely, if somebody, or, educate the person on that, right? I would then need to explore what it is that they don't know, or, try to elicit where I might be able to provide information. But if somebody, on the other hand, is like, yeah, I take CBD, I take it every day, I love everything about CBD, then I might offer some feedback. I would ask permission. Is it okay if I give you some information about CBD? And I'd say, there's a lot of CBD products that are on the market now that advertise themselves as being various strengths of CBD. But one of the challenges is that the marijuana industry is not regulated. So the people that produce these CBD, either pills or capsules or, creams or products, are generally not evaluated to see whether or not the cannabinoid products actually match what's advertised. The industry is still very much evolving the capacity to be able to regulate itself with truth in marketing. And so I would sort of ask, how do you know that what you're receiving is actually what you think you're getting? Because many times THC is added to CBD products because it makes them more rewarding. So I ask, and then I provide limited amounts of information. And then I ask, so what do you think, right? Because it's very easy for me to say, you can't smoke marijuana, you shouldn't smoke marijuana. And then the person would say something like, oh, but I'm going to, or no, but I can. And they're right, right? People outside of a structured setting, generally people have the capacity to go do what they want to do. So asking for what somebody already knows and asking permission to share information and then asking them what they think oftentimes puts me in a stronger position of responding, where I don't seem like I'm just reacting to the fact that people smoke cannabis. And this is a skill that leverages motivational interviewing techniques, which is really a style of communicating where we evoke and elicit change talk from people. And I've sometimes been surprised that when I talk to people, I ask them what they know, people can be very defensive, particularly in front of an addiction physician, around their marijuana use. So if I'm open to, tell me what you like about marijuana. And I might even use an amplified reflection. It sounds like you like everything about marijuana. People might say, well, no, I don't like everything about marijuana. And then all of a sudden I now have a window to talk about change talk. But it oftentimes puts me in a much more effective position to be able to get information and act than compared to if I'm simply, spending all my time blabbering on and trying to tell somebody what to do. And then there's something called the brief negotiated interview, which is if somebody, where I do ask what somebody might be ready to do or what changes they're ready to make. I might ask, what changes they might be ready to make around their marijuana use. And then quickly, because again, the brief negotiated interview is thought to be a 5-minute intervention, make a targeted plan negotiated with the patient with a concrete follow-up. So I'm going to say, okay, like I understand that there's things you really find helpful about marijuana, but you also notice that it's affecting your capacity to, say, work regularly, be as present at home or present with your children. What I might do at that point is to say, okay, well, it sounds like you've got good reasons to cut down. What do you think, right? And then based on what they say, okay, come up, you're going to smoke, let's say, less cannabis. You'll smoke one less time a day for the next week, and then arrange for us to check in. That'll check in with one of my colleagues, like one of my FUD counselor, or social worker, or if I don't have those in my office, like a nurse manager. And there's a lot of people who are psychiatrists in private practice, so I just check in with my patients directly and ask how that went. And then do a little, from quality improvements called PDSA, do a little planning around what did we learn and what can we, based on what we learned, what can we put into place so that somebody can be more successful or engage their motivation and interest to continue. So these are some concrete tools. I also mentioned before we turn it over to questions, I oftentimes get asked about, so are there medication treatments for cannabis use disorder? And I don't have the slides up today, but I'll just throw out a couple things about the treatment of cannabis use disorder. This talk was really around how do you practice addiction medicine, which we usually think of as involving the FDA recommended treatments for opioid, alcohol, and tobacco use disorder, right? So the molecules that are approved for those things are buprenorphine, methadone, and naltrexone. And we know that you can give methadone to people who use cannabis, and methadone seems to work just as well as it does to people that don't. Same thing with buprenorphine, and we think the same thing with naltrexone. And smoking cannabis in general is not great for recovery in general, right? But that the use of medications for opioid use disorder seems to be as effective in people that do or don't use cannabis. So that all being said, although I don't have the literature in front of me, that also appears to be true for tobacco. People respond to the same medications for smoking cessation in similar ways, regardless of whether they smoke cannabis or not, although smoking cannabis does put somebody at increased rate for smoking other things too. So smoking cannabis makes it harder for you to quit smoking cigarettes if you're regularly smoking. So that all being said, there are no FDA recommended medications to treat marijuana use disorder or methamphetamine use disorder or cocaine use disorder. There are a few things that there are some small studies suggesting that gabapentin at a relatively high dose, 1,200 milligrams twice a day, can help reduce marijuana use. The challenge with gabapentin is there are people that really seem to really like gabapentin. And it's not every patient, but I have had patients develop actually like what looks like a gabapentin use disorder, which again is not, gabapentin traditionally is not thought of as a fully addictive drug, but there are people that then overuse gabapentin rather than marijuana. So it's not a risk-free medication to use, but if people can tolerate it and don't then to go and develop a dependence on it, gabapentin can seem to help reduce marijuana use. And N-acetylcysteine, which is actually over-the-counter supplement that's also used in hospitals to help with protecting the liver in the case of acetaminophen overdose. N-acetylcysteine, also at a dose of 1,200 milligrams twice a day, does seem to be helpful. But again, relatively small studies. Neither of these medications are FDA approved for the treatment of cannabis use disorder. And I'll also just say clinically, although I've used both of these medications in people who smoke cannabis regularly, I have myself not found a ton of success, just clinically. People's readiness to change their marijuana use, N-acetylcysteine or gabapentin might help, if somebody's motivated to make a change, but they oftentimes don't, fully treat the cannabis use disorder nearly, anywhere near as effectively as like buprenorphine or methadone do for opioid use disorder. And that these medications sort of help support people when they're ready to make a change, but in somebody that's not otherwise interested in changing their marijuana use, I've not found N-acetylcysteine or gabapentin to have much of an effect. And then the last thing I get asked all the time is, so what about dronabinol and nabilone? Dronabinol is a THC derivative. It is actually THC that is in a capsule and you swallow it. And it is FDA approved for appetite stimulation and for HIV-related wasting. It's interesting that many people who use medical marijuana don't seem to respond to the FDA-approved version of THC, probably because when you use marijuana, you smoke it, and it goes into your lungs, it hits you much faster. And when you swallow dronabinol, it doesn't seem to have the same effect on, giving you like an immediate effect the way that smoked or inhaled THC does. And so dronabinol, and interestingly, dronabinol does not seem to be effective at getting people to reduce their marijuana usage. Again, probably because the rate of onset, the THC effects from dronabinol are so much more delayed compared to inhaled marijuana smoke or vaporized marijuana or dabbing. There's other ways you can use cannabinoids. And then nabilone is a synthetic THC product that it's a synthetic version of THC. It's the same molecule, it just it's not derived from the plant, it's sort of synthesized THC. And kind of similar to dronabinol, it has similar sort of FDA indications and does not appear to change people's cannabis use. There is another cannabinoid medication that recently hit the market last year called Epidiolex is the trade name for it. It is actually cannabidiol, and it's approved for very specific types of juvenile seizures. Cannabidiol does seem to have anti-seizure effects, but again, for only specific types of seizures. And one thing on the FDA packet insert for Epidiolex or cannabidiol in particular is liver monitoring, right? That there was some effect on liver inflammation. And so I think back to the unregulated industry, right? This industry that's sort of promoting, oh, CBD, it helps with everything, with pain and, good for what ails you. And they're giving out a product that mimics an FDA-approved product, in this case, Epidiolex, but it's not associated with any sort of packaging, right? So people that they buy CBD, let's say, or THC CBD at a head shop or a dispensary, are oftentimes not then sort of their LLCs aren't monitored the way that somebody who's getting Epidiolex out of the doctor's office, the product insert would recommend sort of regular monitoring. So this becomes one of the challenges in this current regulatory environment. So in summary, and then I'll sort of, this is my email address, but I'll take some questions here for the next 10 minutes or so. In summary, patients that use marijuana do seem to respond to the medications for addiction treatment. The using marijuana does not seem to be helpful to supporting long-term recovery from whatever substance somebody might go into treatment to be abstinent from, but it doesn't impair somebody's response to medications for addiction treatment either. And then I'll sort of end on this big question I always get asked is, so if somebody has a quote prescription for medical marijuana and they come to a treatment center, what do I do, right? Like, because they are authorized to use the substance. And I guess say that the same way that if somebody is prescribed, the combination of alprazolam and, oxycodone extended release and dextroamphetamine by a provider does not mean that when somebody shows up at a treatment program that we're obligated to continue, addictive medications. That it would be up to the treatment program to evaluate for what's the indication for those treatments and whether or not we would continue those treatments or not when somebody was admitted to treatment. And so I've yet to admit anybody to any treatment programs with them associated and then sort of authorize their use of marijuana for a medical reason. Now, I suppose it could be possible that somebody has an intractable medical condition for which safer alternatives aren't available and for which, cannabis might be necessary, but I've yet to see that in actual clinical practice. Like it's theoretically possible. And in that case, I imagine, the treatment program has to make some, accommodations to help that person consume cannabinoids in the way that it would be medically necessary. But in many cases, the sort of medical necessity when people go to treatment of continuing marijuana does not support, the continued use of marijuana if somebody was, let's say, in a residential or day treatment program. And again, in my experience, oftentimes, once people are discharged from day treatment or wherever they're being monitored, they go back to using whatever they've decided that they're going to go use. So if they decided they're going to be abstinent from marijuana, then they don't go use. But if they decided that they're not going to be, then they go do that. And that becomes the work of the treatment program to help support somebody's making decisions that's effective for their health. Rather than feeling obligated by the fact that somebody has a card that protects them from criminal prosecution if they happen to be caught with marijuana. That doesn't mean that we're obligated to continue the marijuana. Okay, so I'm going to go over to questions, and I'm going to start with a question on that comes from Al about, can a New York State medical cannabis card work in other states like Massachusetts to buy medical cannabis? And the answer is no. Each card is state specific. So if you have a medical cannabis card in, say, New York, it will work in New York, but it doesn't apply to Massachusetts. You would have to get a medical cannabis card in Massachusetts for it to count in Massachusetts. So the cards are state specific. And then there was another question around whether the PowerPoint is available, and I'm absolutely happy to make this PowerPoint available, no problem, to anybody that requests it. And at this point, I'm open for any other questions that anyone else might have. And there's a question and answer box that I can use to answer any questions that come up. I can give it another minute or so, but otherwise I can also give everybody 5 minutes back in their day. So you folks know the minute if anybody has any other questions. So there was one thing that I had initially mentioned, but then it turns out I was muted, is that there is a poll after this talk. And if you could fill out the poll, it really helps both C4 and certainly would help me give me feedback on what went well and what didn't go well this afternoon. So if so after I'm done sharing my screen, there's going to be a poll, and if you could fill out the poll, I'd really appreciate it. Okay. So there was another question by Joy. In physicians who approve medical marijuana cards, can they be prosecuted by the medical board if the patient goes on to relapse to opioids? So I'll answer the question two ways. Any physician can be prosecuted by the medical board for any kinds of misconduct. So the question is giving somebody a medical marijuana card misconduct if the patient goes on to relapse to opioids? And I think the answer is no, not necessarily, unless there was some direct connection between the patient's use of marijuana and they're going on to use opioids. Because smoking marijuana does not necessarily mean you're going to relapse onto opioids. And if the kind of like we, you know, in the rest of medicine, we do trials of treatments, right? So we sort of see is trying this treatment going to be helpful compared to that treatment? And some treatments have risks. And so as long as the, I'm not an attorney, but I'll sort of give my opinion. As long as the physician sort of documented reasonable medical decision-making in offering somebody a medical marijuana card and sort of documented the rationale for what the thought was and talked about the risks and benefits and alternatives, as long as that discussion happened and that the patient was aware of the risks and, you know, it was a medically reasonable treatment, then if somebody then goes on to relapse to opioids, that's not considered to be the physician's fault. Now, it's a different thing if the physician's, let's say, prescribing opioids to somebody who says, I'm addicted to opioids, and the physician says, well, here's more opioids, right? That generally crosses the threshold to medical misconduct. But in this particular case, if the physician is sort of doing their due diligence, sort of documenting whatever medical decision-making that they think is sort of appropriate for giving somebody a marijuana card, and then the patient then goes on to use opioids, I don't think that counts, or I would not sort of think that that's a prosecutable medical misconduct, because there's all kinds of, you know, risky treatments, but we offer them to patients if we think the benefit of those treatments is going to outweigh the risks. So, and I recognize, by the way, I'm talking almost out of both sides of my mouth. I'm not suggesting that marijuana is a great treatment for everything, but there are some things where, you know, other treatments, the patient might be able to tolerate other treatments, and, you know, the patient and the physician determine that, you know, smoking marijuana is a way to proceed. Not something I'd recommend, but I also don't think that that's prosecutable malpractice either. And in fact, the states have sort of authorized physicians to have that authority. And then if there's another bad outcome, like the patient goes on to relapse to opioids, that's sort of unless you can demonstrate that the physician knew that, you know, prescribing marijuana would cause that patient to relapse to opioids, oftentimes no, that tends not to be prosecutable. Okay. And I think we'll go ahead and wrap up there. I'm going to turn it back over to the C4 team, and thank you so much again for spending part of your afternoon with me, and thank you also for participating in the poll that's going to be shared, because that really does help C4 and me. All right, thank you.